The broadcast is now starting. All attendees are in listen-only mode.
Hello, everyone, and thank you for joining us for today's HPA webinar. We have Dr. Hauk here with us today to present. Dr. Hauk is presently the Director of Research at George Fox University and is a research scientist at the University of Rochester Medical Center. He obtained his physical therapy degree from Virginia Commonwealth University and received a Doctor of Philosophy degree from the University of Iowa. Thank you, Dr. Hauk, for presenting for us today. You can go ahead and get started.
Thanks, Marcus. And I just want to say how pleased I am to be invited to do this presentation today from the HPA Catalyst Group. I'm super excited about the topic, and I want to acknowledge my co-collaborators from George Fox University and University of Rochester. So the title of my talk is, Do You Really Know Your Patients Using PROMIS Scales to Implement a Biopsychosocial Model of Care? So I want to acknowledge to you that the fact that I'm talking to you here today about outcome measurements is a surprise. After all, they are just measurements. In these first few slides, what I want to do is share with you how I've learned about how outcomes are associated with how we see our value in healthcare. So PT providers are strong advocates for meeting patient needs. But what patient needs we target evolves from our framework. So our framework really is provided by our focus on pathokinesiology and kind of applying that pathokinesiology model to the ICF model of health condition. And we can see really here how, our body structure and function, is connected to participation, which is like our ultimate, kind of victory for patients, is getting them moving again and mitigating the effects of their health condition, and then trying to take into account personal and environmental factors. And so the way that this translates to clinical care is by our focus on either a tissue-specific diagnosis or a movement system diagnosis, and then how we can remediate some of those by, kind of focusing on impairments in physical function, things like range of motion, strength, and then mitigating pain interference. And then, recently there's good evidence that PTs have fully embraced like outcome measures, but the reason there's a question mark there is because it's really not clear if clinicians have. So clinicians oftentimes see these patient-centered outcomes as more of an administrative thing than something that they need to address clinically. Nevertheless, the success that we've had and the value that we put into healthcare really is centered around movement and how we can optimize patient movement, for better health. So the question is, why change? And how does this affect, our value? So despite our success on our patients' behalf using the pathokinesiology, kind of ICF framework, can we do better? So if we start with data, at least 1/3 of symptoms in primary care are not explained by the primary diagnoses. These are symptoms like fatigue or apathy, depression, things like that. So most physiologic diagnoses are associated with comorbid psychosocial symptoms. And so this is, really great study too, by the way, if you're looking for a good read on this topic. In addition, another illustration of a motivation to change is the target trials that are trying to implement the psychologically informed physical therapy care kind of noted that an area for improvement that most PTs, trying to implement this, kind of identify is communication. So what can we do better? So the things we can do better are related to unexplained symptoms, trying to address unexplained symptoms that we don't typically think about, expecting comorbid psychosocial issues to occur, and then addressing communication that's associated with these issues. So the shift for us is really going from a, pathokinesiology model to something that includes more psychosocial domains. And this is really challenging our beliefs and attitudes toward what are our value, where we think our value is in the healthcare system. So typically we've really been focusing on movement, and that had to do with impairment and pathokinesiology, but now it's this layering of psychosocial issues on top of that that's really pushing, I think, our profession, our beliefs, and our attitudes. And this is kind of supported by these new, I mean, really current integrated descriptions of care and the hybrid approach in GSBT by Hodges, the cognitive functional therapy, from O'Sullivan, and then, this early on adoption of it, the psychologically informed physical therapy. What's really clear from all this is these leaders are kind of suggesting to us that we start to see our value not just in movement and pathokinesiology, but also in these other psychosocial domains of health. So I want to shift gears a little bit and not just talk about the value of where our focus is and what opportunities those have for us, but also ask the question, are we doing enough, or can we, underscore the importance of scalable treatments? And that's really kind of something we've been focusing on in Oregon. So this is an illustrative example of why this might be important. So this is a cost analysis from the Northwest of the United States of 6 states. We see Arkansas, Idaho, Montana, Oregon, Washington, and Wyoming. And those states, they were looking at, kind of utilization in, some different practice patterns in PT. But what's really, I want to draw your attention to is what the y-axis is on this graph. And so the y-axis here is the total number of patients that might have qualified for physical therapy. And this is a kind of a large scale, medical record review. So there's a lot of issues with accuracy and things like that. But the basic thing that really stands out is that the number of people here that actually went to PT is just these kind of lighter shaded areas up here. And you can see that most of the people that might have gone to PT didn't go or didn't have access for some reason. And so what we could know from this is like the opportunity may be there for us to really expand our impact on the healthcare system. And this reinforces the idea of scalable treatments. And so the open question is would different models increase our overall impact? And basically by different models, meaning reallocation of our own selves as providers to where we're doing a little less for more people. And the opportunity may be to address some of these psychosocial symptoms that are unexplained related to disease. So essentially, one of the things that happens to me when I talk about these two issues with clinicians is I commonly get this perspective of, physical therapists do address psychosocial, kind of health by, using kind of classical interviewing styles. And it's clear that we intend to, do a good job in this area. But what's commonly unrecognized is that there is strong data out that therapists' judgments on psychosocial factors are really not that good. And this is combined with the fact that these new integrated approaches, have, quite a few different scales that they're recommending. And so there's a lot of complexity in that. And it's difficult to know where to focus in terms of, measuring something as an outcome to demonstrate value in the healthcare system. So why should we switch to PROMIS? What does this offer us that these other scales, might not, or how's it a little different? So let's just kind of do some basic interpretation of PROMIS, and then as we go through this, I'm going to ask for some responses from the audience to start to think about what different psychosocial scales you might choose to kind of adopt to kind of expand PT or better address patient issues. So what makes PROMIS different is that they're person-centered measures, which others are also that way, but it combines this kind of unique combination of things. So they're person-centered and they're reference to the general population. And so what you're going to get with PROMIS in terms of a score is you're going to get their kind of average, how the person sits relative to the 2010 US Census or the average American person. And so they're also, capturing, all the domains of health, which not all the domains, but these specific biopsychosocial domains that are you can see here, which includes physical health, mental health, and social. And so as you look at these different domains, some may be familiar to you, like pain interference and physical function. And then we can see some that are new, but we know that are important, like sleep disturbance and fatigue. We know are important to patients, yet we don't routinely assess these. We also could see, in terms of mental health scales, there's choices to make. So these are negative mental health scales like anxiety and depression, but we also see down here a positive mental health scale, self-efficacy for managing chronic conditions, which might also be relevant. And then if we want to choose something in terms of social health, well, here's a participation scale, which we're familiar with in terms of the ICF model, but we haven't routinely assessed either. And this is a patient's ability to participate, or would we rather ask about satisfaction, or would we rather want to shift this and talk about support? And so we can see here social isolation may be a big factor for us. So what I'm going to do right now is I'm going to, see what the audience thinks in terms of what social scales or mental health scales or other physical scales you might think would be good to focus on in terms of expanding PT care or getting involved with psychosocial assessment. So I would ask you to volunteer your picks for what areas of new areas of psychosocial assessment you would want to treat and which ones you might want to assess clinically. So go ahead and get on the chat room and type in something there, and I'll be able to see it if you type it in. Okay, so no takers so far. So hopefully you're at least thinking about that. Okay, so if you're thinking about what psychosocial scales you might want to include, I'll keep the chat room open here so I could see them for a minute. I'm going to show you what a panel of experts recommended in terms of adopting the biopsychosocial model. So this is just another look at the biopsychosocial model and some of the different scales, and then how they might be used to graphically illustrate patient status. But here's a selection of different scales that the expert panel recommended for assessment of health overall. Let's see, we have physical function, sleep disturbance, fatigue, pain interference in terms of biological, and then depression, cognitive function abilities, and ability to participate in social roles and activities. So trying to give a biopsychosocial look at healthcare in general. And this is, was proposed by experts that developed the PROMIS scales. So, so what we can now look at is well, how should we select these scales in PT, and what should that be based on? And so I'm going to share with you now what we did to select the different scales that we use, and then invite commentary on that as we go through. And so we had two criteria, and basically we wanted to pair measurements with patient needs and treatment. And so we defined patient needs as, symptoms or health constructs that we thought would be, highly prevalent in the patients that we see in our clinic. And then, but we wanted them also to be actionable. The treatments, if you know about them, that's good. But if you can't do anything about them, then it's not helpful, right? And so what we thought is if there's evidence-based treatments for that particular problem, and if we feel like it would be prevalent enough, then we wanted to try to focus on that. So here's the scales again. And so I don't know what exactly you were thinking you might choose, but here's the ones we chose as a first stab at what might be important to patients and improve patient experience. So in the physical health domain, we know that pain interference and physical function are really routine, really. If you're using patient-reported outcomes, they pretty much match what something like an oswestry or a foot and ankle ability measure or a DASH might detect and track for you. So they're not really that different than our legacy scales, our current disease-specific scales, but they are important still. But fatigue, which we also felt like would be relevant to patients but isn't routinely assessed, so we added that, so another physical health scale. And then it was a difficult decision in terms of behavioral health because we didn't want to include, didn't know which ones to include, because many of these have been found to be important. So we decided on the self-efficacy for managing chronic symptoms because we felt like this was something that we integrally wanted to try to change or alter or improve as part of the course of care. And then finally, the social health scales, we haven't really committed to a particular scale yet, except recently we added the satisfaction for social roles and activities. So we don't have data on that yet. So our first attempt, and most of the data I'm going to share with you today has to do with fatigue, pain interference, physical function, and self-efficacy. So just to put this into the context of, kind of where we're at today maybe, or where most people might be at, and then transitioning to, the PROMIS. I have just a very simple 53-year-old male with low back pain. Kind of some of state-of-the-art types of assessments might be oswestry, some pain assessment. Start back tool is also important that we commonly use. And then, you would layer on more scales if you were trying to capture a broader domains of health, and maybe some depression, other mental health scales, fatigue, as they kind of met certain, kind of stratification criteria for the start back tool scale. So for us, what we've been doing is assessing just on all patients these domains here. So kind of connecting them to this kind of, pie chart of a patient's kind of psychosocial and physical status. And so you can kind of see here, we're using kind of the self-efficacy symptom management to kind of represent this, the psychological factors, and then the pain, the physical function and pain interference are kind of representing this kind of green, which is going to end up being like the kind of standard of practice that we're currently doing, and then we're adding fatigue, and then we'll evolve, currently the satisfaction of social roles and responsibilities. So that's kind of how PROMIS matches up and some of the decision making that we use to kind of select specific scales. But the second question becomes, and should be, a priority for everybody is like, well, how's this really feasible? There's all these different scales, and implementing them, there must be issues because it's fairly complicated. So one thing that really helps out is using the computer adaptive testing scales. And essentially by using these scales or this approach, we lower patient burden significantly. And with the testing's kind of clear now, like scales that are, kind of very sophisticated, like the physical function PROMIS scale, which includes over 200 items, can find a patient's score in about a minute or less. And so that's kind of true of most of these. So each domain costs you about a minute in terms of, workflow or patient burden. And so for us, 5 minutes is a good limit for that. And so using 4 or 5 scales seems fairly feasible in the normal workflow of a kind of typical clinic or large health system. So then how do you access these computer adaptive tests? Well, so a small clinic can access them using an iPad app. It's about $500 a year for access to 10 iPads on the computer adaptive tests, and these can be manually translated into WebPT. And that's how we use it in our workflow. And then there's evidence large health systems are able to implement this using, the API that PROMIS provides. And so feasibility is, demonstrated at large clinics and small clinics. So also, what's different about the scales? And what really surprised me was the interpretation of the scales really changed my view of patient care more than I expected. So our current, scales are all disease focused, and this is to make them more responsive and relevant to the patient's case and why they came in. But the PROMIS scales take a completely different approach. They are not disease focused. They're person focused. So it means that essentially if they're asking about physical function, it's not physical function relative to their problem. It's just their overall physical ability unrelated to their exact health condition. And so self-efficacy is a, related to health conditions. So it's more about, how they manage their symptoms. But that's an exception really in the PROMIS framework. So pain interference is unspecific to their particular pain, and fatigue is global in terms of their overall fatigue problems. And so this was really interesting in terms of the focus for us as providers. So typically patient comes in, my primary problem is the knee. What the PROMIS scales do is say, okay, they come in and then now what I'm measuring is not their function related to their knee, but related to them as a whole. So it keeps the conversation with the patient about their overall health, not just their specific episode of care. So the other thing that really changed is that these are normed to the 2010 census. And so we have the ability, by using the PROMIS scales, of knowing where a person sits relative to the US population. So if they're close to the average, worse than the average, or better than the average of an American a person. So this next section, what I want to do here is, so we have kind of some perspective of just some aspects of the PROMIS scales that are different, but I just wanted to give a little look under the hood. So there's some trust built in terms of the validity of these scales. And so I'm going to describe in these next 3 slides just a little bit how they work, and then what the score interpretation of, and that'll help us apply it to the data I'm going to show you. So essentially, we only use computer adaptive tests because we feel like they're more responsive and have lower floor and ceiling effects. And so the way that the computer adaptive testing works is there's this item. The first item is kind of at the middle of the scale and is usually the same for each person. And then based on the patient's response, the algorithm chooses the next best item. So if they're worse than that initial question, then they choose a lower item. And if they're better than that initial question, then they choose a higher level item for that particular health domain. And then essentially you get something called a T-score, which is a standardized score based on the normal distribution of the reference population, which is for most of the PROMIS scales is the US average. So, okay, not to mire you in statistics, because that's not what we're going to do, but this is a normal distribution graph. And so the T-scores are represented here on the x-axis. And we can see that a 50 here for all of the PROMIS scales is going to be the average of the reference population, which in most cases is the US average. And then a 10-point shift in either direction is 1 standard deviation. So if someone comes in with the physical function score of 70, well, we know that they're 2 standard deviations above the US average. And if they're toward the middle, then they're kind of fairly close to the average American. And then if they're low, well, then now they're kind of much worse off than the average person. So if you look under the hood at the scale, that's still available to you. And so this is what it might look like. So we can associate the T-scores with kind of the patient's potential perceived difficulties with very specific activities. So there's items listed here, and they've been categorized here in sit to stand, walking, and stair ascent, and you can see how each of the items kind of scale some. Okay, so let's use our example of a patient that gets a 40 T-score. So they're 1 standard deviation lower than the average American on this particular element or health domain, which is physical function. So let's focus in on the stair ascent right now. And so what we could see is that, it kind of splits these kind of colored boxes. Well, the colored boxes represent the patient's likely response given a 40. So essentially green, blue would mean no difficulty, red is unable, and then that kind of scales between the different colors. And so we can see the first item for stairs here is up and down stairs at a normal pace. And so a person with a 40 has little to some difficulty, potentially with that particular item. And then if it's, so a few flights of stairs, well, that's much difficulty. And then they're unable to climb several stairs. And so you have the ability to look under the hood some with these scales, as well as getting a reference to the general US population. Oops, okay. Okay, so there's of course a lot of detail and a lot of validity data on the PROMIS scales, but that's not the intent for today. And so essentially there's some resources for you if you're interested in that. And this one was developed by Ryan Jacobson and George Fox, and it's a very specific explanation of how the physical function scale works, and it's based on a publication we had in the Journal of Geriatric Physical Therapy last year. And then for other kind of data, which is, and videos and things like that about the PROMIS scales and how they work, healthmeasures.net is the resource for PROMIS. So, okay, so now we know a little bit about what the details of this system is like and what these measures, kind of do and how they might interact with the patient. Now we could kind of look at what's going to happen in the normal workflow that you would have with a clinic encounter. And so this is the way it operates for us at George Fox. Essentially we administer 4 scales routinely, which takes under 4 minutes total time, and so that fits nicely with our intake workflow. And essentially the scales are physical function, pain interference, fatigue, and self-efficacy, as we've described. And essentially what we have now is we have their view of how they sit relative to the US population prior to our initial assessment. And so if we know that fatigue is high and pain interference is high and physical function is high, well, then we know that all 3 of these will be relevant as we go in, and we'll want to explore those as we go into the interview. And so we feel like this helps us know our patients better. So this is what this looks like, and also we use this for a study with medical doctors. And so essentially, this was a way for us to kind of illustrate to physicians, how to interpret these scales. And so essentially what you see here, we call it our PROMIS report card. And so you see here, we have each scale is represented by a single line. So we have physical function here, self-efficacy of symptom management, pain interference, fatigue, and then the physicians wanted to add depression. So for this particular data, depression is included. And then we're using the color coding to kind of indicate where the patient sits, relative to this kind of this reference population that's, used for that particular scale. And so green would mean better than average. The yellow is kind of under, but close to average. And then red is, really significantly worse than average. And it's, it's a standard deviation here. And then, so many times we use like a half standard deviation worse than average to indicate a pink zone or, nearly, kind of severe symptoms. And so what we did is we showed the data from the computer algorithm to the MDs, and then we asked them to rank how helpful they thought this information was, prior to going into their encounter with the patient. And so I'm going to show you that data next. And then note that we're going to use the same color coding when we look at some other graphs. So green's always going to be better than average, yellow close to below but close to average, and then red significantly worse than average. Okay, so this is the data on the helpfulness, and we're going to focus in on the providers, which is down here. And then on this particular graph, we have the 0 to 10 scale here on the X, and then the percent of the providers that marked it at that particular score, and the provider's helpfulness is here in the red or the brown. And so you can see that essentially for not all cases, but in about 70% of cases, the providers found the data helpful, and oftentimes they would say that they were, that some of the data was expected, but they gained in that case an idea of the severity of the symptoms because they could look at it relative to the US population. And then other providers would say sometimes they were surprised, like they didn't know that fatigue would be a problem. And that kind of matches that previous discussion that we had that said some of these psychosocial factors that the MDs weren't focused on because they're thinking about the diagnosis or different, lab tests and all the complexity of that encounter. And they may have missed these kind of either peripheral or something central to the patient, but not something in their routine assessment. And so then we also asked in this same same situation is when we administered the scales, we asked the patients to rank the difficulty of filling it out on a 0 to 10 scale. And so that's also down here. So in this case, it's going to be lower scores would mean less difficulty. And so we can see here's the patients in blue and their responses to that difficulty ranking. And we can see that most of the patients here, nearly 75% were under a 2, so they didn't really find it difficult, and very few found it more difficult. Now, this would look really positive for the scales, and you think, well, of course, this means they're going to be successful. The providers love them and all that. But in fact, the providers did not want to adopt these scales. And the main reason is because they questioned whether they were actionable. And so essentially, if they had somebody who had fatigue as a symptom that was associated with a diagnosis, but they had no treatment to offer for the fatigue because they'd already addressed the physiological problem like diabetes. That's about blood sugar. It's not about fatigue. And so essentially, unless there was specific, scalable, actionable treatments associated with the symptom that was being identified or the health construct that was being identified, they weren't for implementation. So that was a good lesson for us. And so, one of the things we're going to talk about in a minute is how we, really focused on actionable interventions for these problems. But before we do that, we're going to shift to the prevalence of these problems at our rural health clinic in Oregon. And so this is data that I just pulled off from our September poll. And so you can see here some of the profile of the patients. So pretty typical outpatient setting with a lot of spine patients, and then kind of a mixed bag of other kinds of orthopedic problems and a few non-orthopedic problems, and several patients with multiple areas involved. Now I'm going to leave off the number of treatments just to kind of keep that as an open question. So here's our data, okay, for our initial encounter. So this is the initial evaluation data that's on these 198 patients. And so what we can see here on the y-axis here is the prevalence of that severity of symptom, okay? And then here are the different scales or measures. And so pain interference here is first, physical function is next, fatigue follows that, and then we have self-efficacy here far to the right. So again, the green is above the US average, so the US average is here in blue. And in this case, the yellow is 1/2 standard deviation below average or worse than average for that scale. And then the red line here is something called pass threshold. So the red above the red line means they have even though their symptoms are worse than average, they're at an acceptable level for that patient. And then below the red line means that they're at an unacceptable level for that patient. And this is based on research that we published last year. And so essentially these pass thresholds, we can see that about 65% of the patients are below the acceptable levels of pain, and something like 35% for physical function, and then higher levels of unacceptable fatigue and low confidence or self-efficacy in this patient group. So this was good for helping us understand, who is in these different zones, kind of severity of symptoms across these kind of focal areas for us. But they didn't really tell us how these different symptoms combine. So the question is if somebody has high pain, or really they run the table and the rest, and really all of them are involved, or is these fatigue and self-efficacy scales, because those are the new ones, do they occur in isolation? So there are people with really just bad fatigue and coupling with physical function and pain that don't have self-efficacy symptom problems, or vice versa. So this next data we're going to look at kind of addresses that. And so it's a little bit complex, but it's basically to kind of get the color coding so we can understand this pie chart that I'm going to show you in a minute. So essentially what we did is we said, okay, so people who are in the yellow, okay, are just slightly worse than average or better we made them all blue. And so there'd be all the people that were just in the blue zone or the light blue zone. They're people who, have what we would either call mild or minimal problems. Now, people who had only PF and PI that were like in the red or below the acceptable symptom state with really normal, yellow or better for fatigue or self-efficacy, they're going to be in the green. So this is, kind of matching our current pathokinesiology view of treatment. They would be, in the green, basically. And then the kind of brighter blue here were people that had either physical function or pain that was higher, and then their fatigue score was high. And then the yellow, kind of thinking about, kind of yellow, yellow flags, essentially, so mental health scales, where self-efficacy was higher, but fatigue was relatively, not as bad. And then the red stands for people who have all the different scales were severe or significant. So this is our pie chart using that color coding. And so you can see, you'll start with the percentage that has patients that are doing pretty well. And we can see that essentially there's about 20% of the people would be what we would call within normal limits or within a half standard deviation of the average for that scale. And then about 20% had fairly, kind of what we think of as physical function and pain interference without really overlying fatigue or self-efficacy issues. And what surprised us was the proportions of people with either fatigue combined with pain interference or physical function and self-efficacy combined with pain interference and physical function as kind of specific areas that would need to be addressed to really enhance patients' experience. And then the group that just had all their scales were low. Okay, so be sure to kind of put your questions up on the chat board as you have them. And then I'll just ask Marcus. Marcus, can you see any questions that would be good to address now in terms of the interpretation of these scales?
We did have a question from John DeWitt asking, what is the frequency of using the PROMIS that you use, e.g., do you administer every visit?
Yes, we do. And it's a great question because, if you're in a large health system, it means there's a lot of data storage and workflow and these kinds of issues, right? And so what happened for us is we were planning like an intermittent kind of administration, but what started occurring is the providers themselves, once they got used to using it, wanted to know some of the scores on a every visit level. And so that in particular has to do with self-efficacy and fatigue, because those are highly responsive to kind of behavioral health kind of approaches, so they can change really quickly. And so like self-efficacy, if a person's confidence is changing rapidly or something you really want to address in that person, they could have a different score just even in a visit or two, and you might expect that based on kind of what you're having the patient do. And fatigue was also kind of because it's connected to depression, and we'll kind of go through that in a minute. You'd want to know if those scales are moving in the right direction. So I think there's a lot of differences in how that's addressed. Anything else, Marcus?
We have a couple more actually. Does PROMIS speak to your EMR?
So yes and no. So in our GFU clinic, which is a smaller clinic, okay, outpatient practice in a rural town in Oregon, we use a standalone iPad and then manually transfer the T-scores into WebPT. For my experiences at University of Rochester, and I know University of Utah also does that, they've integrated the API, so this kind of technical thing that allows them to integrate that into Epic. And so at U of R, there's an outcomes page that comes up, and essentially the scales are presented as a tab in the Epic, EMR, basically. And then was there another question?
Yes, there's two more actually, three now. Are you seeing PROMIS used at all in home care where we are already required to use a comprehensive OASIS assessment? What are your recommendations and your experiences?
So I don't have experiences in home care. So I guess that's my answer.
Awesome. What are your recommendations and our experience to take the information and discuss with the client upon reviewing the results?
So that is really the whole, kind of $1,000,000 question. And so I would say that is the most profound effect that PROMIS scales have had on my practice and the people that I know that are using it. So essentially what happens is for us is, so we get this profile walking in, right? And so let's just use this as a graph. So I'm going to do a case on this in a minute, but let's just say that they're all in the blue, all their scales in the blue. So when I go in, I'm going to say, so remember those questions you answered on that iPad coming in? Well, you're kind of indicating to me that you're doing really well. So what's your main reason for coming in today? Because it sounds like when you answered those, you answered them as very positive. So how can I help you? And that frame, usually something like that will frame it in a way that they really kind of express their goals to you, related to their overall kind of reason for coming in. So instead of it being like, okay, I want to walk farther or some patient specific goal, it's really their kind of general reason for coming in and the benefit that they see in interacting with you. Another way that is kind of, I think, more significant is the self-efficacy and fatigue scales. So a good example is a plantar fasciitis patient I had, a few weeks back, and essentially their plantar, they had chronic plantar fasciitis, was about a 60-year-old person, was walking 10 miles a day basically, and which is amazing for somebody who's that functional who has plantar fasciitis. So it's like, okay, why is their self-efficacy scores so low? Because I think it was in the 30s. So that's just to kind of help you understand what that T-score is. That's more than one standard deviation lower than average, which the floor effect for that scale is not very far off that kind of range. And so that's a pretty bad score. And so essentially I started talking to them. So what brings you in today? And then after I established what I thought might be some therapeutic alliance, I posed the question. I says, well, those scales you filled out when you came in, you indicated really low confidence in managing your chronic, your foot problem. I says, can you help me understand why your confidence is so low? And so the patient immediately perked up and he says, well, I have two questions. I said, well, what are they? And the first question was, well, is it really hurts sometimes? And is my bone is broken? And so I says, well, that surprised me. And so we kind of went through some things and I kind of reassured them that their bone isn't broken. And then I says, anything else? And they said, yes. And they says, I don't want to stretch it because I'm afraid, can it rupture? And then so I says, no, your plantar fascia is really strong. There's no known like cases, in the medical literature of people rupturing their plantar fascia from stretching. And so I guess those are some examples of how, why the title of the talk and why we feel like PROMIS skills are really powerful in terms of addressing, what the patients are really there for, some of the questions they might have. They can help us elicit these kinds of things from patients. Any other questions? Because those are really good ones.
We actually have had a couple more pop in there. The next question is, for the PROMIS national norms, does the reference population contain many older, frail persons?
That's a great question. And the specificity of that, I can tell you're really interested in it. So what I can say is I'm not 100% sure that they're very frail. I do know that what I would guess, so it's a guess, is that it would be the same. The inclusion of those people might be very close to the same, prevalence as is present in the general population. And the reason for kind of speculating on that is that the size of the population and participants were in the 20,000 range or thousands of range for some of the scales that I'm thinking about. But it would be somewhat dependent on which scale we're talking about, because they all have different population-based data. But most of the scales have very, very large sample sizes. So my guess is that would be true, but I don't know specifically about very frail elderly.
The next question, do you see using PROMIS being the direction we will be moving in regarding use of patient-reported outcome measures?
So, I mean, obviously I'm an enthusiast, and the reason I see it is because the ease of use is so much higher than something you might try to build from, the disease-specific measures. If you think about trying to build something that's going to go into a bundled payment system, to kind of show that, hey, we have good outcomes related to, diagnosis X, Y, or Z, right? You can simplify all that because the PROMIS scales are, kind of generic and can be applied across all the diagnoses. So that would be the first, reason that they just simplify that problem dramatically. And then the second, so in terms of a data information or kind of implementation point of view, they're much better. And then secondly, they've shown responsiveness to change even in very specific diagnostic situations. So like knee arthroscopy in young people. We published a paper in American Journal of Sports Medicine this year that shows that they're as responsive as the KOOS and the IKDC scales. And so, and they've shown, good responsiveness in knee OA patients. And then they've also shown, the same kind of thing in ACL reconstruction patients and in patients with spine problems. And so what's unique or interesting about that, which isn't obvious, is that, they're competing against disease-specific scales that are trying to detect change, by asking very specific questions about their particular pain experience or function related to that particular problem, where PROMIS doesn't ever reference anything particular to that person's medical condition and is instead asking these questions that are much more global about how they're functioning. So that makes that really interesting, that even though the questions are much more global and not specific, that the patients are still responding in ways that makes them responsive. And then it also fits with our desire as health providers to really address the holistic problems of a patient and not just their kind of knee or joint part.
And we had one last question. Have you seen improved objective outcomes as a result of using PROMIS as a result of the patient being approached more holistically?
Well, that one, I have some data on that, so I think I'd like to come back to that question. So Marcus, can you ask me that again in a minute?
Of course I can, yeah. And that's the last question.
Okay, great. So let's keep going. Okay, so essentially what I think we've answered, at least at our first level, is like, okay, did we, we kind of had to, as you guys were faced off with that large, table and different scales, it's like daunting to think about which scales to pick. And so, we took our best guesses, and what this data really does is say, hey, the prevalence is there and they're occurring in ways that are unique. So they do add to our patient interaction in ways that helps us understand an individual. And so it's supported by the prevalence data that we currently have. So the next question is, are the treatments actionable? And so we had to come up with ways to really expand our current, repertoire of treatments that we provide the patient to include actionable elements for fatigue and self-efficacy. We have physical function under control because that fits really our focus on movement and pathokinesiology pretty well. Impairment-based approaches are effective, and so, or at least optimized. And so now the question was, if we were really trying to address fatigue or self-efficacy, what's best to use, and are we skilled in providing those evidence-based approaches. And so this kind of summarizes some of what we were doing. And then there's a paper here that we were able to publish last fall. So let me just kind of give you some idea of this targeted approach. We've kind of covered this some already, but this will kind of help you, look at the details and what, kind of cases emerge and what they look like. So basically, I've got 5 cases here. The color coding is consistent. Okay, and so essentially what we're doing is I've arranged them in the order of pain severity. So low pain is number 1, high pain is number 5. And so that's kind of, detailed here. So the first case you can see is all green. So this person's all better than average. And so the question is like, why are you here? So this was a young man who had shoulder pain before, but got a new job. And so essentially what was up with them was they were coming in essentially because they were worried that this new job involved warehouse work, which they were going to be lifting boxes and stuff. And they wanted to know the chances of reoccurrence of their shoulder pain. And so essentially that helped us focus right away. This is a one-time treatment kind of thing. And so we could, kind of do some of the assessments to ensure that, their shoulders in good shape for prevention, give them some kind of prevention, home exercise program to work on, and then they could recheck as they wanted to. The next case I'm going to do is number 3. So if you look at number 3 here, you can kind of see there's pain, physical function, fatigue, and self-efficacy kind of listed. So we have 2 greens and 2 reds. And so the red here is pain interference, and that's pretty severe. It's almost 2 standard deviations worse than normal. And then self-efficacy is low, and we want that to be high. So it's over a standard deviation low. So the patient has low confidence and a lot of pain, but their fatigue's not a problem. And, physical function is within a half standard deviation of normal. So this person's a track coach, fairly young, but they're having some running related foot pain, and they're obviously worried about how to manage it. And the pain is bothering them or interfering with their life. And so the treatment here really focused in on, building confidence and managing the problem, and then trying to kind of do something about the pathokinesiology or the traditional treatment approach for that problem. So, okay, so then the next one is an example of high fatigue. So we see that number 5 here, if we look, it's 3 reds and a green. And so essentially the surprising thing about this is that their confidence in managing their problem is fine. It's equal to, somebody that manages chronic conditions. So in the case of the self-efficacy scale, it's not the U.S. average. The reference population is people that, manage their chronic conditions. So they're doing as good as most people who manage chronic conditions. And so that suggests that confidence may be okay, but the worst symptom really is not pain, even though pain is over 2 standard deviations worse than normal. What's even higher than that is their fatigue scale. And so this particular person was coming in for spine pain or had been referred for spine pain, but they had a comorbid history of cancer that had been treated and was in remission. But essentially, the hypothesis was, in kind of sorting out this patient's problem, is that really these other symptoms were being aggravated by this fatigue problem that was coming from the comorbidity. And so this patient basically underwent, kind of more of a cardiac rehab problem where they were, focused on their physical activity and restoring their confidence in their ability to move and their aerobic capacity. And what ended up happening is that hypothesis ended up being correct. And then these other 2 domains of health kind of self-corrected independent of treatment for spine pain. And so that was pretty significant example. So it was a good illustration of how PROMIS scales help you get at these comorbidities at some level. And then these other 2 scales here were, an example of how all the different scales are significant. But what's interesting is we have for number 2, it's like the pain is only a standard deviation worse than normal. So it's bad, but not terrible. And then you still have all the symptoms in all the different categories. And clinically, I hear a lot of times that, well, hey, if it's not, if these scales would be more useful for people who are really worse off. And so this is a good example of somebody who's more typical and has all these different domains of health as a problem. And here's somebody who's really in the tank, basically, in terms of their healthcare needs. And so in this particular case, the PROMIS scales help us navigate that kind of unraveling of trying to address self-efficacy. The fatigue could be related to different things like depression, or sleep problems, and it kind of helps us relate to that. Okay, so those are some different cases. And then, what I want to do now is just emphasize this idea of scalability before we go into looking at some of our other data. And so, essentially we really do focus on trying to use the scales to stratify, and you can kind of see how we do that a little bit. And then we try to scale them so that we can, reserve our, resources to see as many patients as possible. And we still do, for more complex patients, your typical kind of treatment patterns. Okay, so this I put here just to kind of emphasize, what a shift adopting a new scale can be, and what a commitment it is to try to move the needle on that scale, or kind of hold yourself accountable for changing that particular scale. And so I chose, here we're showing you fatigue. So fatigue is a fairly complex symptom that can be influenced by a lot of different factors. And so it could be, if fatigue is high, you'd want to evaluate your red flags and disease processes. You need to evaluate sleep, probably, behavioral health or depression. Fatigue is a common symptom that's associated with depression. And then finally, you would get to physical activity or cardiorespiratory fitness. And so essentially, if sleep was okay, there weren't any red flags that you could identify, and the patients aren't depressed, well, then physical activity would be the next option. And in that particular case that we talked about a minute ago, that's kind of how it unraveled, and that's how we could focus in on the physical activity component. For self-efficacy, it's much less complex. Here we have basically low or high confidence. And so, the threshold score that we were able to establish is around 45. Okay, so higher than 45, confidence is probably okay. So there's some clinical judgment here if it's close to the average. But when it's low, we're kind of thinking about cognitive behavioral things, skill mastery, and those kind of things to bring back that confidence in managing their symptoms. So what I'm going to show you, so the question was earlier about outcomes. And so obviously this data is case series level, so very low level and, small samples. So you need to consider that when you look at it. But this is that same prevalence graph of the repeat patients that we have. And so you can see, again, this is the intake assessment, and you can see there's not many in the green. So they're pretty bad off. Essentially 70% nearly of the patients in this, subsample of our group had, unacceptable pain and other kind of symptoms connected with that. And so drum roll, here's our outcome. So this is the same, exact data at our discharge point. Okay, so, and this is 105 patients, and of course it's spread across all these different orthopedic, diagnoses. So essentially what you can kind of see here is we're doing pretty well. We got a lot in the green. So the green has, kind of doubled in size for most of the different scales. The red is down 20% for pain, and about half of what it was originally for physical function, fatigue, and self-efficacy. And so what I would say is, what's interesting for us is we're using this feedback to try to, kind of refocus, our training and skills to address these specific areas at a higher level. And this is almost my last slide, so I have 2 left here. So just as a scale, point about how well we're achieving scalability, you can look at our, average number of treatments to kind of reflect that. So for this group that you just saw in the data you saw, the average number of visits is 3.1. So I think it's pretty low, and there's a fair number of one-time visits. So we can also kind of look at, how responsive the scales are. And so in this particular case, this is the effect size index. So a 0.5 would be good, but a 0.8 would be great. And so we can see that the responsiveness across all the scales that we have here is, good but not great. But when we look at the scales for only those people that were, kind of low to begin with, or they were at an unacceptable level to begin with, the responsiveness goes way up. And so essentially here now they're all great. And so this early data, which is preliminary because this would be, a smaller sample essentially, what this is saying is that it looks like that these scales will be very responsive in patients that are low to begin with. And then in support of this, if we also looked at the odds ratio, if you're low to begin with, what's the odd of you being at an acceptable level at the end of the day, so at discharge? And you can see here we're doing pretty well with pain, physical function, and fatigue, and a little less well with self-efficacy. So that's our current outcome data. And then I'm gonna end the data slide with this one, and just to kind of give you an idea of what I think is something that's really important, since we're doing scalable treatments and we're decreasing the number of touches per patient. I think it's important for us to create a check. And so we're calling this the feedback or feedback loop. So patient comes in, we do the PROMIS assessment, we do our treatment, okay, and then essentially they get discharged. And then after discharge, we're creating a feedback loop where we try to call or contact patients and then get some sense if they're either because either they're doing well or not doing well. So the idea is that with minimal treatments, what you're doing is trying not to cure them in your episode of care or your encounters with them, but then to get them rolling in the right direction so that they can take care of themselves, or you can set up an interaction with them where you're touching them intermittently and then they can eventually get to where they want to be. And so we have some minimal data on just the self-efficacy scale, because we're focusing on that, of where some of the people in this data set, which is like 19 people. So we just started doing it. We're at discharge and then at our 1 month follow-up where they were. And so what we can see here is that even though at the discharge, the people that were at an acceptable level of self-efficacy is only around 70%, at the follow-up discussion, they had gained, more people had gained, improved to an acceptable level. And then the caveat of this, it would create another encounter for you with your clients so that then you could redirect them if they weren't at an acceptable level, or you had some, goal that you identified with them on the phone, that you could redirect them back into a treatment encounter. So this is an important part of what we're trying to evolve. And we think it's really important to integrate this if we're going to do this kind of scalable treatment approach. So in summary, the positives so far, there's a lot of positives related to prevalence. The clinometrics that we have are strong and moving us toward using the scales. The evidence-based treatments are available to us. The feasibility is good. Our outcomes, are what I showed you. And we firmly believe this is helping us expand into these new kind of psychosocial domains that we've been challenged to push into. And so the reasons for caution are, of course, we need lots more prevalence data. Some of the scales have more clinometric, validation than others. Predictive prognostic data is lacking. And so even though we're using some of it for stratification, we don't know that that's valid yet. And then there aren't any randomized controlled trials that show that this works better than not doing it. The active user group is small, and so we're looking for partners. You could see by the fatigue scale that it's definitely a big shift in thinking for PTs, requiring training and kind of support in terms of how they move into those areas and try to be accountable for those patient problems. And then I've had PTs directly ask whether we should be expanding in the way that we're doing. Okay, so I'm open to more discussion. Thank you very much.
Thank you, Dr. Houck. We have had a couple more questions pop in the chat box. We have a question asking, do you foresee / have you had issues with insurance approval implications if a patient reports normal physical function, pain and fatigue as in case 1, and receiving approval for treatment?
Well, the answer is no. I mean, you can see that our number of visits is really low. So it's, we're not, typically extending that patient's care very much. And so that may be one reason. The other reason is we do have credibility now with the the payers, because they know that we're not overutilizing. So I don't know why we haven't, but we haven't had any problems in that domain. And I think the third thing is we're a university, and so we have a sliding fee scale, and we take some insurances or not others, and we also require patients to pay up front sometimes. So we also may not be typical. So we may be avoiding some of the the standard issues people face, basically.
And we just have one more question. What does the FU assessment entail? Is it a repeat PROMIS?
Yeah, so the follow-up, you mean I think what you're referring to is the 1-month call. So that new feedback loop, we repeat the PROMIS scales, and then we also ask the PASS question. So I don't know if you're familiar with that, but it's the patient acceptable symptom state. Super simple. It's a yes/no response to, do you find your current level of activities and symptoms acceptable, or satisfactory, I think is the wording. And so essentially that gives us a sense of, whether they feel they're acceptable. And then so if they answer no to that, irrespective of their PROMIS scales, the callback person, which in this case is a PT student, is directed to kind of explore with them why it's unacceptable, and then kind of direct them to come back, if they want to explore some new goals with the therapist.
And that seems to be it. If there are any other questions, please type them in the questions box now. If not, once again, I'd like to say thank you, Dr. Hauk, for your presentation today. We really appreciate your time. Thank you to all of our attendees. We at HPA really appreciate all of the time and effort you put into showing up to our webinars. And we just hope that everyone has a great rest of your day. Thank you.
Thank you. Thanks for having me.